So what's the difference between TRT boosters and TRT, the testosterone replacement therapy? We're going to find out after this, so keep watching. Hi, I'm Mike with Balance My Hormones, where we help men and women on their journey to optimal hormone balance. If you're new to the channel, please subscribe and leave comments so you don't miss future content. So today I'm here with two good friends and also very knowledgeable and founders of the Medical Health Institute in Miami. And we're going to discuss their experiences and their knowledge about TRT boosters or TRT. So I'm here with Miguel and his brother Carlos. How are you guys today?
Hey man, how are you?
Good.
Thank you for coming. Thank you for coming to our home.
Coming down to Miami.
Yeah, it's good to see you guys. It's been a while.
Yeah.
Yes.
But no, this is always good to see friends, especially other friends in the industry. So whilst Balance My Hormones is the UK platform and clinic, it's good to speak to our American friends and cousins on the TRT here in Miami. So why don't you tell us a little bit about yourself, Michael, and then we can start on the main topic of the difference of TRT boosters and TRT.
Sure. So people don't get confused because you said Miguel, which
Miguel,
you are
so,
correct.
yes.
That is my real name.
Okay.
Michael is my work name. It just happened to come along the way because I got discriminated along the way, and I just one day Michael stuck, and now Michael is all over the place. Emails, and to change it, forget it.
All right,
Stay as Michael.
Easier to pronounce.
It's a good name too. It's a good name. And then your brother Carlos. Carlos.
His name is real.
Yeah, my name's real.
And you both are the founders of Medical Health Institute.
Yeah. Okay. So kind of like you, this was a lifestyle way before it ever became, way before we had the fortune right now and the luck of calling it a business now. And it started way in our early teens and 20s. We were athletes, extreme skiers, snowboarders, surfers, and we were always, we always had a high degree of standard for fitness and all things health. And I think, Michael's discussed his story at the young age of 22. He was struck with erectile dysfunction, right? That's for most people watching. I mean, you could just imagine what it could feel like to be at the peak of your prime, great shape, awesome athlete, and be dealing with this situation. So, in that, his kind of Herculean effort into fixing that situation, we found this niche, right? We found this kind of place where we saw that more than 85 million guys that reported.
25 million, and those are just the reported.
This was just reported, and so we found that this was an area that it was personal. I saw him go through the struggle, and so we said, hey, we can probably help a lot of people.
Yeah.
And just like everything that you focus on and measure, and we continue to grow, and we really kind of delved into the dynamics and the specifics and all the other areas that come along with optimization, and so we kind of made this available. We're a very congruent practice in the sense that we try everything first. I said, everybody here is eats, lives, and breathes this stuff, and so we just help people kind of make the mental shift, and we like to think of the medications as tools, but more than anything is about empowering people with knowledge about how their body functions so that they can get to the place where they want to be.
Oh, that's excellent. So have you had any experience then, both of you, with testosterone boosters? To stick with today's topic, have you tried it with patients? I mean, I would say, and tell me if I'm wrong, there may be different categories of testosterone boosters. So right. You can have the ones that they kind of sell over the counter, right. Testosterone boosters, which would be D-aspartic acid.
Yeah.
The other one would be the more POMs, or prescription only medicines, which would be maybe N-Clomiphene or Clomiphene, yeah. Which is the prescription one.
HCG.
And what's the other one?
Gonadorelin, Kespeptin.
Kespeptin, gonadorelin, yes.
Or the LH gonadotropin. So,
yes. Or human what is it? Human chorionic, no.
HCG, human chorionic gonadotropin.
Menopausal.
And HMG, but that's more for the FSH. So
human menopausal.
Now with each of those, you've got the pros and your cons.
Yes.
Yeah.
So, first of all, do the non-prescription, the over-the-counter, have you seen them work?
Personally, from talking to many patients that have taken them, you know, because usually they'll fill in the medical forms, taking some testosterone booster. We'll typically look what's inside of it, and even when it has the maca, the
Maca and aspartic acid.
Yeah, even if they have that, because I think some studies show that when you take maca after a specific certain amount of time of taking it, it's kind of transient.
Yeah.
The results will fade away. And how I like to explain it, let's say your T levels, which we know total testosterone is pretty much irrelevant, but that's what most people focus on. You know, let's say they were in the 400 range, and by luck, they got into the 500 range. But at the cost of lifting their ALT and AST liver enzymes, you know, usually we would see that even though they would be a little higher, which we didn't know what their baseline was, their liver enzymes were a little high. I don't know how those supplements are in Europe, but here in the United States, we like to go with NSF certified supplements, which is kind of the only way to guarantee quality, purity, and efficacy in a supplement.
But you don't know when the patient comes to you on the boosters already what they were taking, because they could simply just be from anywhere. And they could be contaminated potentially. Because you, with your clinic, you're controlling for NSF.
Yes.
But these others can't and don't.
Yeah, and that's an important point. You know, I like to always base it off of labs, right? Because people can say whatever they want. But when we look at the real objective measure, which is your blood markers, you know, a different story surfaces. So what I've seen from personal experience is guys that take these over-the-counter boosters, which I don't recommend particularly. First of all, I haven't really seen them do much of the work that they're really, the main reason why they're doing it in the first place, right? But what I have seen is that total testosterone will go up, but then the free testosterone will only move 1 or 2 points. And so total testosterone, you got SHBG in there, you got DHT. So some guys, you know, have lost their hair and they come with these side effects. So for all you guys watching, you know, I don't think that over-the-counter testosterone boosters are really the way to go. And like Mike said, they kind of have an end of the rope. And even the legitimate testosterone boosters like Clomiphene and HCG, you know, the ones that we talked about, I've also seen people that, you know, there's so much stimulation that you can do, right? It's kind of like saying that we can drive our car from here to Canada with the pedal to the metal and never taking our foot off the accelerator. Eventually, you're going to have kind of an end of the rope to that.
So that was the next one. You beat me to it. N-clomiphene and clomiphene. So obviously, just so people know, clomiphene is a selective estrogen receptor modulator. So it inhibits parts of the body, some body tissues, from estrogen, from sensing estrogen, and then it agonizes other parts. Like I think in the liver, at least this is the traditional clomiphene, which is made up of 60 to 70% N-clomiphene, and the rest is U-clomiphene.
62% is U-clomiphene, and the rest is N-clomiphene.
So with that, though, you're saying you've taken a patient, let's call them a virgin, to any form of testosterone manipulation other than maybe the over-the-counter, and you guys you had your doctors trial them on, was it N-clomiphene you have here?
Yeah, we do clomiphene.
You do clomiphene, so you can get it compounded.
And HCG, and some people are more responsive to one or the other.
I think that's what we were going to tell you, that we've seen some patients take it and their levels will jump by 1,000 count.
Yeah.
Okay.
And their free T will come up, you know, from like 10 to 25. Your ranges are different, but
so that would be between 30 and 40 nanomolars per liter.
Yeah.
It'll be the
It'll be significant. It'll be a significant jump.
And then we've had guys that have a 200 jump on their total testosterone. Again, we like to follow more of the free than anything else.
Well, of course, because
the
you
way
can
we
also
like to describe it, total testosterone is the money you have in your bank account. Free testosterone is the money you have in hand right now.
Right.
The one that you need on a daily basis is the one in hand, which is biologically active for your brain tissue and muscle tissue.
Yeah.
So we've seen some guys that don't have an increase, and I've noticed that the guys that don't have an increase, this is anecdotal, but I am inclined to thinking it's a metabolic disorder or some type of metabolic issue, because the guys that I've seen are overweight, so they can have mitochondrial dysfunction, metabolic disorders, so maybe the gut dysbiosis and imbalance they have, it's not helping them absorb the medication well. Again, that's anecdotal more than anything else.
Of course. I mean, I would say that our patient target group that does the best with clomiphene citrate, because that's all that we have in Europe and the UK, because they can't really do compounding, and those N-clomiphene never got approval at that one time because they didn't think that it met the endpoints they're looking for. But the young patients who will use this, and in some of our guidance, we have to follow certain guidance, like the British Society for Sexual Medicine. They have recommended for patients who want to maintain their fertility to try a course or treatment for clomiphene, and the younger ones seem to do better, but not all. Yeah. And there can be side effects like visual disturbances.
Right.
And so it's not really always recommended. Some patients, the very few, we've seen get improvement in libido. Yeah. Have you seen the same with some of yours?
Yeah. There are definitely, some people are more responsive than others. I think we almost use it as a precursor to see how someone is going to react to testosterone, because again, you're going to have an end of the rope to that. And I think that the underlying question is really where, people that are watching that are kind of judging whether, should I do a testosterone booster or should I do the real thing? It's usually based on fear, right? Yeah. And that fear comes from this sense that, I don't want to shut down my production. And while that's true, right, that while you're on injectable testosterone, there's oral forms now that have a very short half-life, so your LH and FSH don't actually have time to shut down.
Like Natesto?
Natesto, and here in the United States we have compounding pharmacies that do oral sublingual tablets that are amazing. But I think the underlying question is, for those guys that are concerned about shutting down their production, I always like to think about it this way. Well, number one, if your production sucks in the first place, then what are we worried about your production anyways? Because we're a big part of what we do is we talk about environmental factors, things that we cannot change, right? So we've noticed a 53% decrease worldwide in the micronutrient balance on our soils, right? You got environmental toxicity, EDCs that are endocrine disruptors. And so living in a modern society today, your endocrine system is constantly being subjected to these attacks. And so if your production is subpar, you and I both know that that's not going to get any better. No. And it's actually going to decrease every single year, right? So if we're talking about your natural production and your natural production sucks, then we really shouldn't be talking about your production, because here, at least in the United States, these lab markers have been decreasing time and time again, right? To kind of compensate for the global, the population, right? And so now normal, right? The range is so wide. For us is, between 300 and 1,200. Yeah. So that is...
Well, actually, they brought it down. It's 900.
It's 900. Well, there's a couple labs...
It used to be 1,100 in the late 1990s.
Correct. And there's actually...
Traditional labs are up to 900. Yeah. Like if it's in sort of a wellness alternative lab, they'll go...
1,200.
I have labs that said, actually, at 1,080.
Yeah. That's common. The point is that, here, this is my metric. This is the one thing that sold me, where it's been, documented that back in the 1960s, the average testosterone rate for an 80-year-old man was 800. Whereas today, because of these things that we're talking about, we see labs every single day, and we're lucky or hard-pressed to find a 35-year-old about 500. So the question is, if you're 35 years old, your natural level is at 500, and an 80-year-old had 800 in 1960, is that normal?
No.
It's not normal.
No.
So what are we talking about your normal production anyways? Your normal production has been compromised. So instead of going through all these boosters and halfway measurements, I'd rather do the real thing. As long as it's under a therapeutic environment, therapeutic purposes, and therapeutic doses, obviously being prescribed by a doctor, I think it's a safe thing to do.
I think for some, though, like you said, it's a fear. And I think not just of shutting down the HPT axis, but it's usually their partners don't want them to affect their fertility.
Right, that is a point,
and they can kind of derail them from being on TRT or veto them from being on TRT.
That's one of the things that we're trying to get off the ground right now is study on the TRT tablets, the rapid dissolve tablets that we took. I told you I was on testosterone for 6 years. My LH and FSH have been completely suppressed for 6 years. My testes have shrunk. Sperm tests, basically none. Yeah. I got off the injectable because I want to have a kid in the next year and a half, but I didn't want to get off the testosterone. I'm like, once you get off, you never want to get off.
Exactly.
There's no way I want to get off. So I kind of understood the science, and I said, let me pulse it on a daily basis. So as long as you have a shutdown throughout the day, it should technically kickstart your LH and FSH because you're getting in a pulsatile form, which is natural rhythmic.
More closely to natural rhythm.
Exactly.
Yeah. And how did you feel on it? How did you?
Great.
Did you
we got
great.
You both on
we both did it.
We did different protocols just to test it. Okay. I was pulsing LH and FSH once a day. He was doing it twice.
Yeah. I thought you say you were pulsing your own LH and FSH from the gonadorelin.
Gonadorelin, yeah.
So the half-life is 2 to 4 hours depending on the demand of your body. On our way down, let's say 4 hours later, when I knew I was coming off the peak, I would pulse it with gonadorelin.
Okay.
So to kickstart my natural production, and I started with seeing within 2 to 3 weeks, my testes started to become plump again. My ejaculations were stronger. And then eventually, after I think it was almost 2-3 months, we went to do the litmus test, which was a sperm test.
Yep.
The morphology, motility, and volume of our sperm came back above normal.
Amazing.
Yeah.
That's
And you
good.
know what? And even after that, we've had guys, on the upper range of age that have just been on the tablets because they weren't looking for fertility.
Sure.
But because we knew that they were on the tablets, on their follow-up, we tested for LH and FSH, and they did not come back suppressed. I mean, they were a little bit suppressed.
They were lower, but
they were lower,
like,
but they weren't shut down like you usually
Yeah.
see it on labs with guys with injectable
That's
testosterone. But I
good.
think, that's a really important point because you have to assess that when the patient is coming in, right? So if someone has that fear, and even if they don't mention it, we ask, hey, listen, in the area of fertility and having babies with your partner, where are you? Is it something that you're looking to do right now? Is it further down the road? Or, are you done with it? Because the answer really will kind of dictate the treatment. And, I always like to tell guys, look, if you're trying to have a baby, it's not right now, or maybe it's in the future, there are many strategies that we can use to achieve that, but when the time comes, right?
No, and it's funny that most guys are worried about the fertility, but they're taking Propecia or finasteride,
Right.
Yeah.
which
It's
is 10
not-
times worse for fertility.
No.
You run the risk of being infertile permanently.
And potentially erectile dysfunction, so you
Correct.
can't get the job done.
And you would
Exactly.
would be surprised how many guys would say, I don't care.
Yeah,
Because they want to keep
because they're so
there is a lot of
self-conscious.
pressure in society to
Yeah.
keep the hair.
Yeah.
Eventually, just had to say I don't really care.
Yeah.
I said at this point I give up.
I say,
I'll lose my
well,
hair.
I
don't
say, how
care
many
what it
times do you look at yourself in the mirror? I don't care.
Yeah,
Other
yeah,
people have
yeah.
to look at me. That's their problem.
No, it's just at the end of the day how I
Yeah,
feel. Because
exactly.
I've been battling. I have receding hairlines and it's headed. So we like to explain people testosterone does not cause hair loss. But if you're pre-genetically disposed,
course.
Yeah.
it could accelerate it. And DHC is a contributing factor to hair
Not the
loss, but
cause.
it's not the root cause. The
Right.
root cause would be inflammation and poor blood flow.
Right.
So, yes, could I slow it down? Absolutely. And one of the ways to slow it down is microdosing it so you don't have a spike in DHC. There's guys like me that have a DHC of 200 and could cause a little bit of hair loss. And there's guys that can run with a DHC of 800 and have no hair
Yeah, like
loss.
me. Sometimes I run DHC with 300 and I have a head full of hair.
Right.
Luckily, so.
So getting back to a point on the HCG, I think we were talking about just if someone starts TRT only, there's this fear they're going to lose fertility. I think in the US for a long time, HCG was readily available, especially at the compounding pharmacies, but now I guess it's not as much, which is why gonadorelin took over.
Right.
In the UK, we still have plentiful supplies of HCG. So that what we find many of our patients will be on both HCG and testosterone simultaneously. So that usually reduces some of the worry, but still not as good as having your own LH and FSH being produced. And I think everything works up chain. So let's talk about quickly. So we've got HCG as the other booster. So there are some that will, have you in your clinic when it was more available, have it for monotherapy for HCG when we're talking about a booster, or we're talking about it along with concomitant with the testosterone?
Well, a lot of times, our doctor is very kind of acute to this.
Yeah.
So it's based on symptoms. Like if we don't, if a guy just wants to increase in energy, but he doesn't have a lot of the other symptoms that come with testosterone, then we usually give him an HCG trial to see how he responds, right?
Okay.
And then it's really about assessing his long-term view on therapy, right? Because like I said, I mean, there's an amazing study by Dr. Ramasamy, he's a urologist from the University of Miami. He had, I think it was 200 participants?
Something like that.
Something like that, maybe like 200 participants. So these were men that had been on testosterone therapy for a decade or better without any testicular stimulant, meaning no HCG, Clomiphene, or any of that. And he scheduled it to be a 6-month study. He put them on an aggressive, so basically from a traditional medical standpoint, they were infertile men, right? Decade on testosterone, no testicular stimulant. So he took these men, took them off testosterone, put them on aggressive HCG and Clomiphene.
2,000 units of HCG 3 times a week and 50 milligrams of Clomiphene 3 times a week concomitantly with the HCG.
Yeah, and within 90 days, 95% of the participants had retained full fertility.
Okay.
So that's what I mean. It's, if you're concerned about your fertility, there's ways to combat it.
But-
I always like to say that it doesn't shut it down. It's just that it pretty much puts it on hibernation mode.
And also we use it, some guys don't like injectable. We'll go with the clomiphene.
Yeah.
Well, obviously we like to go with the HCG, which is an LH analog.
Yeah.
But it also could have suppression on your gonadotropic releasing
Yes,
hormones
that's what
as
we've
well
seen
when
as
you use
well,
it
yeah.
long term.
Yeah.
So we kind of go back and forth, but as we say, there's so much stimulation you can do before the light bulb goes out.
Yeah, and you're gonna hit the end of the rope.
And then, so yeah, and we've seen that there are patients we'll start with. We've got some that are still going strong after a few years with the clomiphene. But
yeah, and the one we're playing a little more with, that I've been playing with, and I've seen some good results, is with a gonadorelin.
Yeah.
It's just that the half-life is so short that you would have to pulse it many times a day.
And it's a little more expensive, so
You have to be very dedicated to this form of lifestyle in order to make it work.
so you have to always be near your fridge.
Remember to take it at a specific time, and so it takes a lot of discipline.
It's not right for everyone.
And for your viewers, is if they're going in worried about fertility and they want to get the testosterone benefits and they're taking testosterone supplements over the counter, look, my best recommendation: do a clomiphene. That's what you guys have available.
Yeah.
Freeze your sperm if you can, and you can afford it. And as soon as you can, just get on testosterone therapy.
And always don't do underground.
Yes.
Self experimentation. Get a proper lab done. I mean, I think that your clinic
compounded medication, because people are like, oh, I can get it for $10 cheaper. You're messing with your biochemistry.
Yeah, you really. This is the only vessel that we get, and you want to take care of it. And I think you do a phenomenal job. We've seen it in your labs, and you do a phenomenal job of really digging deep into the biochemistry. And just go to the professionals on this. Look at invest the money in getting a proper lab and having a proper diagnosis by a doctor who knows what they're doing, and that they're looking out for your best interest.
And with an outstanding clinic. So I guess we can call you our friends and partners here in the USA.
For sure.
And we really appreciate the connection.
And they're there, like, call this clinic.
So I think that covers most of our topics for the difference between boosters and TRT, and then the various different types of boosters that there are, including things like the over-the-counter tablets, which we discussed probably don't work in the long run. There's N-clomiphene and clomiphene, which may work for some men and others it doesn't. And then obviously there's our gonadotropins like gonadorelin and HCG added both to TRT. And there's some interesting things we talk about as well that they're trialing here in the US at the Health Institute, like the tablets for bioidentical oral testosterone encapsulated in a certain way, which we can talk about at another time. But really, thanks for coming on the YouTube channel. Please leave comments, let us know your experiences with either N-clomiphene or HCG. We'd love to hear it, and thanks again for watching.